Thank you for joining our Policy Committee meeting today. This meeting is being recorded. The documents which will be discussed here today are available on our website, which is wmc.wa.gov. I am Amelia Boyd, and I am the Program Manager for the Medical Commission. I, along with Becca King, are the organizers for this meeting. Panelists, please make sure your line is muted if you are not speaking. Dr. Karen Domino is the chair for the Policy Committee. Once a presentation is finished, Dr. Domino will open the floor for committee and public discussion. Attendees, if you would like to ask a question or speak, please use the raise your hand function or the questions section. And with that, I will hand it over to Dr. Domino.
Hello, good afternoon, everybody. My understanding from Mr. Farrell is that Micah wants to do his first presentation, is that correct? And that will be on licensing application questions.
Thank you for agreeing to take this first. I do have a child care conflict that if we had it in the last place where it was, I probably would end up having to go pick up a kid. So with that, the background on this is Panel L was reviewing an application, and it became clear that a few of the questions were confusing both to the applicant and being interpreted differently by the applicant and the panel, as well as the staff attorneys that were looking at it. So that confusion in itself resulted in a little project that myself, Marissa Courtney, the licensing manager, and Commissioner Charlie Brown agreed to participate in. And so what you have before you, the initial, not this particular thing on the screen, but the initial review is what came out of the work between Chris Bundy, Dr. Brown, myself, and Marissa. And then what you have before you is what was added later due to inputs from Heather Carter. The most significant change that folks may or may not have an issue with is we have eliminated the question regarding medical conditions. I will say that we are not the first medical board to do such a thing if you were to vote to go forward with this, but we certainly would be minimizing risk of violation of the Americans with Disabilities Act by eliminating that question. In exchange with that, we are simply saying it is, if you have what is defined as a medical condition under the first note, it is incumbent on you, the practitioner applying for the license, to contact WPHP and abide by whatever they ask you to do. We also make it explicit that under the new question 1, which was formerly question 2, or currently question 2, which deals with substance use, that if you contact WPHP and you are known to WPHP, you would be able to say no to question 1, that you have used substances, because you would be within the safe harbor that we already have in existence now on our application.
Micah, I'm a little bit confused. I thought you said we were going to get rid of this question in the first place.
No, the question that we got rid of is the one that says, do you have a medical condition, whether it's physical, mental, psychological, or I forget what the other P word is, that would impair your ability to practice. Question 1 now, under this new proposal, deals with substance abuse.
Okay, thank you.
No problem.
Any comments or about this? I thought it was a good change to get rid of it. I did
agree.
have, for Micah, I was a little confused with the first paragraph. Is that going to be on the application, or is that, it says, yeah, please note the commission does not inquire about medical conditions unless they're notified they represent a limitation or impairment to safe practice.
Correct. The intent is to have that explanatory statement on the application, so we can explicitly tell them there is a safe harbor provision in here, but you must contact WPHP and comply with what they request in order to be viable under the safe harbor provision.
Okay. Then under Yeah, this, and their acknowledgement and agreement by submitting this application, you acknowledge the following. There is just a typo. There's no space. It's 2, 4, 6. Wait, yeah, line 6 in the middle of the sentence in the red, it's to the space licensing authority.
It's possible it's a typo. It's also possible that the formatting that we've been wrestling with on this particular document just shows it as no space, but we will make sure that on the final, in the final version, that there is a space that's noticeable there.
Any other comments?
The only thing I will say is beyond the elimination of the current question 1 and the alteration of the proposed question 1 about mental substances, as we scroll down, we have combined and wordsmithed a little bit on the remaining questions. So we did end up shortening the existing set of questions by 1, I believe. We specified on, I'm sorry, can we go to question 2? That as an adult, have they been one of those 4 things? And then with respect to the other questions, again, it was more plain talking or wordsmithing to make it more understandable to the lay person who does not happen to have a law degree.
So I did have a question. Is an adult age 18? I mean, does that need to be specified? Because I mean, college students are legally adults, but they're immature.
Yeah,
You know?
this is Heather. I think there's a legal distinction between, juvenile court, I think is what they're trying to get away from, because usually those are sealed records and, we're not going to have access to those anyway. So I think they're, talking about 18 and older or charged as an adult.
So is that something, Heather, we should place in, and how would we word that?
I'm not sure a doctor would know, or PA, what, I mean, to me, it's age 18, but.
And I know in the pediatric realm, they talk about reaching mental and physical maturity at age 26. So I know that's a little bit fluid. So.
Yeah, I would have to think about how we would word that to make sure we're getting what you want, because you just don't want the juvenile, criminal records. Is that right?
Well, except I'm not really sure I care about age 18 either. I mean, you don't even go to med school until you're in your mid-20s.
Right, but I think this is trying to get away from all of those things that you did in high school. I mean, if you're charged with as a minor in possession, you're 18, that's an adult in
Yeah,
legal.
I think that's fine.
I mean, it does come up. I mean, we see it in resident applicants who, when they're in college and they're age 20 and now they're age 30, they had a DUI. I have a colleague whose daughter had a DUI in college. I mean, yeah, maybe that may significant, if they go to medical school, that generally has been cleared up. So, and certainly a residency, because all those things come into play. So I guess people want to know about it, but you figure if someone makes a mistake at age 18 or 19 or 20 and gets drunk in college and gets a DUI, I mean, it's different if they, it's really bad and it's a repetitive problem. And now they're age 40, they've completed their training and maybe they want to apply for a license, and now it's haunting them forever. I don't know if it's, but whatever it is, that's our system, I guess.
I think from the perspective of licensing and the parallel considering things, I think anything over 18, even if it was a DUI at that time, is something the panel needs to consider in its totality with the application. I can say generally what the panel seems to do is if it's over 5 years old on a DUI and it's a one-time thing, they go through. If there's a pattern, on the other hand, that's a whole different thing.
Yeah, that's why I sort of retracted my thoughts. I think leaving it as 18 or as an adult or whatever is fine. Because we do look at that and say, yeah, this isn't a problem anymore.
So
This is
are
how,
we supposed to vote on this? Oh, sorry to interrupt.
oh,
Yeah.
no, it's okay. Sorry. This is Heather. I just had one other suggestion for a quick change, and it's in that first paragraph after please note, and it's the first red sentence that says the commission does not or does inquire about substance use history of applicants. I think we don't actually look at history, so I think we want to say does inquire about current substance use of applicants rather than history, and I think that'll avoid your ADA problem, because that's what your question says anyway.
Yeah.
Okay.
Agreed.
And then Dr. Bundy has his hand raised. Oh, he just put it down. Never mind.
Maybe that's what it was.
He raised it
So
again.
I would move. Oh,
Go ahead, Dr. Bundy.
Oh, thank you. I was just going to underscore what Heather said. I think that you just need to make those two things work together because you're not asking about a history of substance use. And I just wanted to compliment the staff and the commission on this change. I think this is this advisory approach is innovative and once again demonstrates your leadership among the regulators. Thank you.
I
So
move that we approve this.
with the change that Heather suggested.
Correct.
Second, John, all in favor? You can say aye, raise your hand. I can't see everyone. Anyone opposed? If not, that sounds great. All right. Thanks, Micah.
Thank you. Thank you so much.
Childcare.
Eventually, yes.
We'll now move on to the original first one, and that's called Policy Determining Appropriate Practices Under IMG Licenses. And Mike Farrell, would you like to present this?
Sure. The next two items, the next two documents arise out of the new limited license that the legislature created last session, which has now taken effect. The legislature created the limited license for IMGs who haven't completed residencies, and the statute lists nominating entities, for example, hospitals, DSHS, Department of Children, Youth and Families, Department of Corrections. All of these entities can nominate an IMG for a limited license. And then they have to work with under the supervision of a physician in the same specialty. They can do it for 2 years and then they can renew it one time. The statute says that one of the nominating entities can be an appropriate medical practice. So I think it's up to the commission to determine what that is. Micah helped draft this, and we would love to get your input on how you want to define an appropriate medical practice. And so Micah put some criteria in here on page 2, or actually the bottom of the first page and top of the second page, that the practice be, of course, located in the state of Washington, and that it be limited to a clinic with in the federal system, such as military, Indian Health Services, or a community health center, or is a clinic with 20 full-time physicians, MDs or DOs, and with an established quality improvement program for its practitioners, and an established supervision program for mid-levels. So none of this comes from statute. This is criteria that Mike and I went over, and we offer it for your consideration. Maybe it's too narrow, maybe it's too general, but we'd love to get your feedback on it.
Alden, I see your hand up.
Yeah. So I'd like to sort of get a perspective on this. This is an opportunity for them to get clinical experience so that they can move on to a residency, so they can get a license. Isn't that correct?
Micah?
So that's correct. This is coming out of for those who were on the rules hearing yesterday, this is the policy, and the next thing is the interpreter statement that is helping implement that bill, House Bill 1129. The testimony given during that bill's hearing related to recent international medical grads, as well as ones that had been here for quite some time, who would get more recent clinical experience, and during that time have a clinical readiness evaluation performed on them that would be submitted to with their residency application.
So I would be careful of making this too restrictive, because the restriction is actually going to come at their ability to get a residency or not. And what I think we're trying to do as much as anything else is protect the IMG while providing them with a pathway, rather than looking at this as that we're trying to protect patients, because I'm not entirely sure how patients are going to be abused by this.
Yeah, my big concern in drafting the conditions, I started out with a much smaller number, and just based purely on my anecdotal experience and my awareness of the health system, is I wanted it big enough to where there was actually the ability to do quality review. I wanted it big enough to where if a practitioner left, it wouldn't immediately terminate the IMG's ability to continue on in that clinical experience role. But I also didn't want a scenario where, they know this guy in say Central Washington who's offering something, and really what it is, and we actually have an example of this where they're offering a residency that's not a residency, and it's basically just slave labor in a research facility.
Right.
So it's trying to make sure that it's on the up and up. It has a supervision program, and it has a quality review program. And if I'm being too out there as far as the expectation, I'm certainly open to changes.
No, I like this, and I think it actually probably expands things over what we have to do, and I think that's a good idea, because I think the real determination about these guys' qualifications would be their ability to actually get a license after they've been through 2 years of a residency.
Yeah, I like it as well.
Yeah.
I thought what you put in is quite good, because you don't want them just in the settings, as you were saying, small private practices. Also, it's hard for the candidates to be able to get letters of evaluation from small groups. They need a larger cohort of supervising physicians to be able to have sufficient letters for a program to apply for a residency, as well as better learning experience.
Okay. So on that, is the number 20 in these DOs full-time appropriate, or just to speak to Dr. Roberts' concern of being possibly too restrictive, is that needing to be lower, or is 20 a good number, or is there another metric?
I originally thought it was too high, but I think it's good. I like it now. I think it's good, Micah.
See, most of the larger institutions, I mean, you may get into semantics of how many full-time physicians. I mean, if you're talking about a hospital, you may have hundreds, right? And even though they may only be working with a few people, there are a lot of folks there. I think it puts them in a place that they can learn more and have more success for potentially getting a residency than working in a small private office.
Right. So I want to make sure that it's clear. This criteria in B is only for non-hospital settings. Hospitals, institutions, and that sort of thing are already included in the ability to name someone. This, I believe, applies only to the concept of what is an appropriate medical practice that doesn't fall under a hospital, an institution, DSHS, DOC, that kind of thing.
Use the word clinic though. So clinic,
Yeah.
is
Yeah.
it an institutional feel? Yeah.
This is Heather. I think you could replace the word, if you wanted to, replace the word clinic with practice that. And I also on 2B, and then you've got the little I's. I'm wondering if, just for clarity's sake, if you want to add in ands at the end of those provisions, just so it's clear that you need to meet all three of those and not just one or two for people reading it.
And then we do have 2 hands raised if you guys would like to take those comments now.
Sure, I don't see them, but just feel free to, whoever wants to speak, speak.
Jeb, if you want to
This
go
is
ahead.
Claire.
Oh, sorry.
I wanted to make sure, I can't get to the document, but I want to make sure that it's not just clinics, it's clinics within systems of care. I know previously as a medical director within group health, we wanted to have some IMGs in some clinics that may or may not have been that size, but the system was very large and had a lot to offer to the IMGs. So it's not just a clinic, but a clinic within a system as well. Is that?
I think you have to be a little bit careful. There's a Vancouver clinic here that's a nice, large, multidisciplinary clinic that would do a fine job with managing these. So I think we have to be a little bit careful about how restrictive we get, because all we're doing is preparing these people so they can start a residency.
Right.
What if we said practice setting instead of clinic?
That works.
That's better.
Jeb, if you want to go ahead.
Great, thanks, Amelia. Good afternoon, everyone. As always, good to be with you. I just have a general question, mostly for my own edification. We note there was a rulemaking on the IMG work yesterday, and then there's a policy statement and interpretive statement. And I'm just curious why the medical commission has taken this approach sort of through 3 different avenues to implement this law. We don't have any concerns. I think it's more just for clarity about how we're approaching this.
Micah?
Sure, Jeb. So the rulemaking yesterday was to deal with Senate Bill 6551. There was a requirement for rulemaking to put clinical experience, the standards for the clinical experience license into rule. We didn't want to, and in between, as you know, 6551, House Bill 1129 passed before we could do rulemaking on that. So yesterday was simply adopting the standards required under 6551 as House Bill 1129. Now, the policy and interpretive statement in this packet are squarely aimed at House Bill 1129. So when we analyzed the language of 1129, the appropriate medical practice was immediately flagged as something that was going to generate a lot of engagement and a lot of people challenging us on what is an appropriate medical practice and trying to shoehorn their way in. And some of the examples that have already been described is probably not ideal. And so the determination based off of legal guidance was we needed to do a policy statement that would allow us to either approve or create a list of approved medical practices. So that's what this policy framework right here is. The interpretive statement is to address basically a drafting issue in the law that doesn't explicitly state that they need to have a practice agreement in place before they start working. We all agreed that was an important piece. It's the same as the way PAs are. I think if you read the law, it's assumed but not explicit.
Thanks, Micah. Much appreciated.
Not a problem.
We do have one suggested edit, and I'll drop it in the chat as well, but I'll do my best not to butcher it verbally. So I'm looking at, as currently written, it says an appropriate medical practice is a practice that meets the following criteria. And then I'm looking at sub A, it says a clinic with a federal system such as military, Indian Health Services, or community health center, or is a clinic that. The feedback we received from our physician on this is that regardless of the setting, whether it's a practice setting that employs more than 20 or is a federal health system, Indian Health Services, or community health center, it's important that they all have an established quality review, improvement, and assurance program for practitioners and has an established supervision program for mid-level practitioners. So we have some suggestions on how to accomplish that. That I'll drop in the chat if it's helpful.
Yeah, thank you. Micah, any comments about it? It seems reasonable to me. They should all have, I mean, one would assume a military, Indian Health Service, and community health center have quality improvement programs and supervised mid-levels, but in fact, we don't know if they do, right? There may be some that don't.
Right. I have no issue with that suggestion. It would require a little bit of a cleanup, but certainly the assumption under A is that they do have those things. But if we need to be explicit, then we probably ought to rework that to make sure it's there.
And then we have a couple of other hands raised. Dr. Khalif, if you would like to go ahead.
Yeah, thank you, everybody. First of all, I just want to say this draft is very unfortunate. Some background about myself, Washington Academy for IMGs. I represent the international medical graduates. And we know that the corporate world is taking over medicine. And this, further contributes to that takeover. I don't know why that 20 physician employees is necessary. This just takes the ability from independent physicians, small practitioners, to hire these graduates. Currently, we're having, nurse practitioners with 6-month degree treating patients independently. And I have a huge equity concern here, right? You are limiting access by putting these strict criterias. And it's pure and simple. It's racist. It's a racist, document that contributes to less doctors of color practicing under the supervision of a physician who passed all the USMLE exams and who are far more qualified than a lot of people I know that I have to subject my own family to go to, even though I know their qualifications are close to nothing. So it's just very unfortunate, and we'll be continuing to advocate for that.
Thanks
Dr.
for your
Khalif,
comments.
what would be your suggested change?
Yeah, my suggested change is any practice that has a board certified MD. That's it. Why do we need to create all these requirements to limit access to people of color? Right? International medical graduates are immigrants, refugees, people who speak thousands of languages, and we're reducing the employment opportunity of those medical graduates and their ability to get into residency and become independent physicians. So it's very unfortunate. I think we should just limit it to that. Any practice that has a board certified physician, use that term, and that will ensure that that physician has the ability to supervise these medical graduates. So that is my suggestion.
Thanks for your comments. I just wanted to make one comment as an academic physician who does participate and has for over 35 years in residency selection. One of the things I think having a larger group, and I'm not sure the number of 20 is the right number, but as opposed to a single physician, is that it's extremely difficult for residency programs to you really look at evaluations from outside the U.S. And these are not just people of color. These are physicians from all over and men from many white countries. So I think this is actually helpful. If someone's working in a solo physician office, without having any background, you will have one US letter of evaluation. That's not necessarily going to help the applicant at all in getting a residency position in this country. We don't have many medical students who are only working in a solo medicine, physician office. They may spend a month there, but they go to school and they work in larger settings. So I think that's what you're going to be residency program directors and those involved in the residency decisions look for. And so you want to have a sufficient number. And I think the number of 20, whether that, I'm not sure, there's no evidence that that's the correct number, but I think it needs to be more than 3 individuals, as an example, from a very small office. That's just my perspective from being someone who picks residents.
Yeah, 3 is like debatable, right? I think at least that is a conversation starter. But like, what is the alternative? We had a huge conversation in the IMG work group about this. You have PAs, you have NPs, you have medical students, you have all these trainees competing for clinical experience areas. And if you limit those areas, if you limit those settings where these people can get that experience, you make it impossible for them to get a setting, right? You're talking about places that employ 20 doctors. That's places that have medical students rotating with them. That's places that have PAs rotating with them. That's places who have nurse practitioners rotating with them. So you're reducing those settings by making it more stricter. That's all I'm saying.
Any other thoughts? Is there, I mean, I don't know what the right number is. Alden, you were.
I agree. I agree, Karen. I don't know what the right number is either, but it seems like it needs to be a fair number and maybe 10 plus or whatever. But just to answer the commenter's question, I think what Karen is suggesting, that the IMG candidate working with 1 or 2 physicians may not get into a residency program for lack of experience. And so it'd be very restrictive, and a person might well waste their 2 to 4 year work experience and not be able to move forward.
That's what I'm saying, yes. There are lots of folks applying for positions, and we're also a popular state. So it is hard, when you're looking at letters of evaluation and settings that people have worked in, to make an assessment of whether you think they might be able to fit into a more complex, larger setting. And people also know about the, looking at letters, they want to often have letters from, multiple individuals in that. And so I just see it as it is not in the IMG best interest to just go to a solo or a group of 2 doctors and work there. I don't think it will necessarily help gain a residency slot.
Yeah, I understand, that concern. I think 3 is reasonable. As I said, I think 3 is a good number. But, all these other, criterias and red tape, I think is not necessary. 3 board certified positions. Let's keep the language simple. Let's ensure that we do not shrink those facility opportunities where these doctors can get that experience.
Board certified, should that be an added requirement?
I'm a little concerned over that myself, because we have individuals, we at the University of Washington, we have a lot of physicians who are board certified in their country, but not in the United States. They're outstanding physicians, and I'm not sure that has to be a requirement. I'm more concerned that they have a quality review program and that they know how to supervise and train other providers. Doesn't, you know, that's just from my vantage point. The ACGME is very interested in trying to get docs to really have a strong experience in quality improvement. And it's also important for self-reflection, which you need as a physician. So
And I think the doctor mentioned, I'm sorry. I think the doctor mentioned limiting to 3 board certified physicians, and I'm not sure whether the intent was to add board certification to whatever number we land on, or no number, or whatever we land on. I was wondering, is it the intent to add a board certified requirement to that as well?
No, my intent was just as less red tape as we can have, right? Let's just make sure the supervisor is quality and trained enough, has the necessary skills to supervise the IMG. So 3 supervisors, any physician who has an unrestricted license to practice in the state of Washington and is caring for patients. If there are a group of 3 physicians, I think that is okay. But I hate to see the facilities shrink, because I know the competition out there. I speak with these medical graduates. I've been participating in the work group, and that is the hugest concern, right? The facilities shrinking. And I think limiting that number to 3 and having those doctors be licensed, that is, I think, so that would at least give every IMG an opportunity to get that experience, because the alternative is no experience and getting back on the couch, right? Which we don't want happening.
We do have one other hand raised. So Khalid Ahmed, if you would like to go ahead.
Yes, good afternoon, everybody. Thank you for giving me opportunity. There are 2 things which I think we need to clarify. One thing is about this whole licensing process. I'm hearing word that this is a kind of, you know, opportunity for a foreign medical graduate to come get experience and get into residency. I do not think that that is the case. So we need to separate this. We're not bringing, you know, they're not coming here to work so they can get into a residency program. Residency slots are limited. Every year, you know, I think at this time, there are probably 10, 15,000 international medical graduates who have passed all these exams across the globe, and they wanted to get into a U.S. residency program. They have not been able to get, and they might not be able to get. So the spirit of this new category of license was that these people will work under a supervision of a physician. Some of them, they might never pursue a residency. If somebody comes here at the age of 45, you know, I don't know if they want to go into a 5 or 6 years residency program. So I think this is not, you know, preparation for residency. We're thinking about these physicians working under supervision of physician, like, well, I would not compare them with the PA, but exactly in the same role. We have no such restrictions on a PAs that where they can work and where they cannot. We don't have. So why we cannot use the same supervision criteria which we already have in place for the physician assistants? I have supervised physician assistant. They work under me. In some other states, I had nurse practitioners work under my supervision. So I would love to get a little feedback from my colleagues on that. But my understanding is this is not done for the residency purposes, that they'll come get the limited license and then they will get into a residency. They might not go into residency. I'm using my example at this age. If I had migrated to United States at this age, I would have not gone for residency. You know, it's a it's a beautiful, so I think this is where we are confusing reference letter and how many people will supervise. So our standard of supervision right now here is that if there's a physician assistant, he is under supervision of a physician. It's not required that he be under supervision of 2 or 3 or 4 physicians. And the same thing is with having a practice, defining a practice as a group of 20. The whole idea or spirit behind this legislation was to address the shortage of the healthcare provider, especially areas where there is a shortage of the healthcare provider. I don't know how many groups we are going to find who will have a 20 provider. I work in a hospital, which is about 250 bed hospital, and we didn't have 20 physicians. And there are a lot of practices. Majority of the practices in our community, especially in the rural areas and in underserved areas, they have only either 2 or 3 people. So I think we're confusing this with the residency. So I think that is something which we need to separate.
Thanks for your comment, Mike. And Micah, maybe you could respond. My understanding is this was for 2 years with a renewal 1 2-year period, but not something that could be a permanent thing. Is that correct?
That's correct. So this license is only valid for 2 years and 1 renewal, so a grand total of 4 years. I think with that understood, and I know that there might be an intent in future legislative sessions to remove that restriction, but with that understood, I think that we also should appreciate that in the case of the PA, like we're talking about, they've got a lot more to lose. The IMG would have a lot more to lose if they walked out the door if there was a problem at the practice. So there's a power differential that we should probably recognize there. Given that, I don't know if we can separate the residency discussion from this, simply because that is what was part of the testimony in getting the bill passed. I recognize that there were other parts of the testimony that dealt with folks who have been here a long time and may not want to go to a residency, but the current state of the law is that it expires after 4 years.
Well, the other thing, Micah, is that in order to get an unrestricted license in the state of Washington, you have to have had at least 2 years of residency.
I think what the doctor was talking about is a scenario where you would have maybe a more seasoned practitioner, IMG, and they would simply work under this limited license for the duration of their practice.
No, I get that. But in order to get, if that license expires, then you're out of luck unless you get into some sort of a residency. And that's why we are talking about a residency, is because we're looking for looking to get people into an unrestricted license. It is conceivable that another law will come through in which they will say, we will have this be renewable in perpetuity and it's a limited license. That's a different situation than what we're currently dealing with.
What we haven't, have we brought up the fact that some of these physicians have had residencies in their country of origin? I mean, I worked with a German physician who was incredibly well trained in internal medicine and pulmonary medicine in residencies in Europe. And why wouldn't we recognize that work as well? And then they come over in midlife, and why would they have to go through another residency? And they've been working in the field for years.
So that's a statutory restriction that we have currently. They have to complete an accredited residency, 24 months. So, most residencies here now, as I understand it, are 3 years. And so we have dealt with the legislature before on trying to get that modified. There's not an appetite to touch that, and so we're dealing with the statute that we have before us.
So then they have to do an American residency for at least 2 years. no matter what their background training.
Claire, there are individuals who work at University of Washington who are trained outside the US and work here. I think the state has an opt-out for that if you wish to work in our system.
Right. There's
Gotcha.
a teaching and research license that can be used in the university and the residency training program setting. There is a pathway to full licensure through that. If you hold I believe it's a assistant or associate professor position or higher for, I think, three or 5 years. I forget the specifics.
Okay.
Any other comments? And again, I can't see everyone, so please feel free to say something. So what do you all think about this? This is a good discussion. Should we bring it up to the whole commission and talk about it more? See what their thoughts are for these possible options, or bring them suggested language, or what? Or people want to think about it more?
If we could, I would suggest maybe providing them an option to consider. As I said at the beginning, I'm more than happy to have this modified to meet what the commission views as a appropriate setting. I mean, given the comments of 3, maybe there's a compromise position of 5 or something like that. And maybe supervision program for mid-level practitioners is not essential, but it sounds like from your comments that a quality review program is.
Scott?
Do we have any data on this? I mean, just the number of physicians. I mean, we're balancing quality of a meaningful residency against available slots, and I'm wondering if we might have just a simple histogram of where these are available and how many physicians they employ, so that we know how many facilities we're knocking out. And I don't know if we have data on the quality of those residencies. I don't know if that would be easy or quick to get, how many people go on to full-time to an unrestricted license.
Scott, perhaps a better thing to do would be to do some sort of a survey of residencies into what they would be looking for. So what would a residency want to see from a applicant? And we could perhaps check with a variety of different residencies to see if there is anything which we could come up with that would be helpful.
Because I will make one statement that I think the first doctor, I'm sorry, I don't see the names, but I thank him for raising the issue. I can say it's nobody's intent here to restrict people, especially I personally live in an area that's a federally recognized shortage area for a lot of different specialties. So I think the first doctor for raising the issue and raising the concern is figure out how we move forward and what is a reasonable number, if any.
Karen, I think what I would suggest is that we present this tomorrow during the business meeting and raise the issues that the public have raised for consideration, and not necessarily to adopt it tomorrow, maybe adopt it tomorrow, but hear what other commissioners have to say about the language and the commentary that we heard today.
That sounds good to me. I mean, I think we don't have enough, we're basically picking a number that we have no evidence for what is or isn't good, other than, I think, one, it's hard to get, oftentimes they require at least 3 evaluations, for programs. Also, a lot of these folks may end up going outside the state for their training programs. We're fairly limited in our state, a lot of training programs. So I don't know about a survey of of residency programs, I would certainly recommend looking beyond the University of Washington.
You know, another alternative could be work in a clinic with at least 3 physicians that are part of a larger system. That's playing with language a little bit, but
Yeah.
As medicine continues to consolidate, it's getting more and more rare to have a small 3, 4, 5 practice clinic. But you could possibly be in a small clinic that's part of a larger organization. So I don't know if that's some wording change to make or to accommodate a smaller number rather than just a flat 20 in a clinic, because that does 20 in a clinic is a pretty sizable clinic.
Is there
You
any
know,
time?
I just need to say as a family doc that the number of people working together has a lot to do with call and the sharing of calls rather than, you know, independent practice or anything. It's I don't know of too many people that work all alone without sharing some of the demands of practice and the call obligation. So to me, there's a certain minimum number that share that, and that's probably 4 or 5 or whatever. But again, we are just picking numbers out of the air at this moment.
Okay, so the plan is we'll bring up this with the discussion items for tomorrow. And that will deal with this one, the policy statement and the interpretive statement too. Micah, do we need to, and Michael, this interpreted statement where those, that do they, is the interpretive statement okay to people? And the other one is the one where we're, policy statement where we have issues?
Yeah, the interpretive statement is very straightforward. It's much easier, and Micah already went over it because they're related and they're both intended to implement the statute. So I would guess there wouldn't be any problem with what the interpretive statement says, which simply says that the practice agreement has to be filed before the limited licensee begins practice.
Do we want to wait to approve that? Or just say that this one's okay, you know, anyone have any comments about that? Do you want to take a vote on this one or not?
I would think you'd want to keep them together since they're related.
Okay, sounds fine with me. All right, we'll move on. Telemedicine.
Okay, this is the draft policy on telemedicine. So currently you have 2 policies on telemedicine, one set of guidelines from 2014 and a policy on continuity of care from 2018 that are outdated, and a recent law that passed the legislature this session really makes the continuity of care policy inapplicable. So what I did with Micah's help was I drafted a new policy, and what I did was took the last draft of the rule that the commission has decided not to move forward on, put those provisions pretty much into this policy for your consideration.
Hey, anyone have any comments about this? I don't hear anyone.
We do have one hand raised.
Oh, okay, sorry, I can't see them. So please say something.
Jeb, if you'd like to go ahead.
Thanks, Amelia. Jeb Shepard again with the Washington State Medical Association. Thank you for putting this document together. Really appreciated this. Did have a question about one of the scenarios around the treating physician not being licensed in the state. And a lot of the scenarios are really clear that this is for a limited time or temporarily. But then there's this provision, if the practitioner knows that the patient will be residing in Washington for an extended period. Just wondering what an extended period is, if this is intended to be short-term basis.
Yeah, that's purposely vague. I get asked that question from physicians in other states who have patients move to the state of Washington. And what I tell them, Jeb, is that you should allow a reasonable amount of time for the person who's moved here to find a Washington physician. And sometimes they don't want to find a Washington physician. So, but the law is what it is. And so I'd welcome any feedback on that. Do we want to set a time period, leave it as is, or do something else?
Yeah, I get where you're coming from.
Alden?
Well, living in a border state, I'm a little concerned about how time limited you want to make this. I mean, I have people there are people that live in Vancouver who get some of their care across the river, some of their care on this side of the river, who need to do telecommunication on a regular basis with these folks, and I'm concerned about doing too much in the way of restricting here.
I've heard of people wanting to have a telemedicine visit with their physician and having to drive across the border, stop at a rest area, and have that telemedicine visit.
Yeah,
that just
and
seems
I think
so
ridiculous. And since COVID has made this more of a thing that everybody does, people like it and they don't want to give it up. And you know, there's a variety of things we have to worry about, such as how do you discipline somebody. But I think that's going to have to be addressed by somebody, by the legislature, not by us. I think if there needs to be some sort of a change that says if you're practicing bad medicine, we can do something.
Yeah, I mean, patients do really enjoy telemedicine, and I think a lot of the practices do, certainly in our border states where you guys are at, or for the WWAMI region for a center. You know, it ends up being a big deal to have patients have to fly down for a visit, you know, because you're people from Alaska, because our physicians don't have an Alaska license, as an example. So I like the lack of determination extend, you know, yeah. I think there'll be a lot of legislation in this space. Don't you guys think so? I mean, it's one of the most trendy issues around. So should we vote on this? Anyone want to recommend we approve this? Motion that?
I'll stick my neck out and move to approve.
We need a
just
second.
for clarification.
Yeah.
Since this is a policy, it has to be sent for secretary review. So what you're voting on is to recommend to the commission that it be sent on for secretary review.
Okay, great, thank you. I'll write that down. Do we have a second for that?
Yeah, I guess I need to.
Okay.
Motion needs to be revised to say that we approve it, to send it to the secretary for review.
Yeah. Okay, all in favor? Everyone?
Aye.
Anyone opposed? Okay, good. Mike, the next one is processing complaints of sexual misconduct through the Sexual Misconduct Analysis Review Team, or the SMART team. We had some issues with this last time, and you've come back with some changed language.
Yeah, we had quite a discussion about gender, I think, at the policy committee meeting and with the full commission last time. And instruction was to get some feedback from ladies on how to describe the concept that we want people from both genders, at least two genders, to be part of the SMART team and also to serve on a hearing panel. Melanie ran this by somebody, I can't remember who, maybe you didn't tell me, with expertise, and this person suggested the highlighted language there, member who identifies as female and member who identifies as male. Oh, and I ran this by Dr. Curry prior to Melanie, you finding your person, and she just got back to me this week, and she approves of this language.
Any comments about this? I like the language.
I like it.
Yeah. Anyone have any negative comments about the language?
No, the only thing I saw on the second page, number 5, just needs the word member again. At least one SMART member, at least one public member, at least one commission member who identifies as female, and one commission member who identifies as male. So it's just a word addition.
Thank you.
Okay. All right. With that change. Yep, great. Second. Good. All in favor, say aye.
Aye.
Anyone opposed? Thanks for the excellent change. All right. Next topic. Interactive and transparent development of evidence-based policies, and we got rid of guidelines. We had seen this before, and Mike worked on this again. Mike, do you want to tell us what you did?
Sure. It was actually a work group consisting of yourself and Dr. Roberts and Ms. Blake and Dr. Yu, I think. I think I got the right people there. Who went over this very carefully and came up with these suggestions on how to better describe our policy development, policy making process. And one of the issues was the pointing out to me that guidelines in medicine really mean something very different than the way we're using them. And the way we use them, it's not defined by statute. It's not in the Administrative Procedures Act, just something that we came up with a long time ago to provide guidance to our practitioners. And now I understand that there's probably maybe not the best word. So maybe in the future we'll be changing that word, but for the purpose of this policy, or this procedure rather, we're going to talk about evidence-based policies and take out the word guidelines.
Thanks. Anyone have any comments about this?
So this may be a little self-serving because I was on the task force that looked at this, but I think it's well done.
Well,
I think it actually.
Yeah. Anyone else? Again, I can't see everyone. Just feel free to say something. If not, do we have a recommendation? This is just an approval, right? Yeah. All in second? Yeah. Scott? Okay. All in favor? Raise your hand or say aye. All opposed? Raise your hand or say aye. Okay. We'll bring this on. The next one. Informed consent.
This was a proposal. I think Dr. Yu is in this meeting, but she proposed that the commission develop a guideline or a policy on informed consent. And then I proposed this to you, Dr. Domino, and you thought it was a good idea. So we're at the very beginning of the policy development stage that we just looked at. And this is the step where the commission decides, do you want to begin to draft a policy on this topic or not. I did a quick look around the country and I found what I thought was a pretty good policy by the Maine Board of Medicine that I put in your packet. Dr. Yu, do you want to add anything?
Yeah, can you hear me?
Yep.
Yes.
Okay, great. Yeah, I appreciate the opportunity to make comments, and also the commission is considering whether to develop this type of policy. You know, having on the commission being, you know, gosh, almost 7 years, and I heard many issues come up about patients and providers, whether things have been documented, how that be communicated, and particularly when giving a procedure and particular treatment. And you know, really boil down to it's about communication. When I suggest this to Mike and Mike trying to test water, and he found out this informed consent from which state is that?
From Maine.
From Maine. And I read through, I found that this is a really good document for us to start it. You know, to have a policy like this, really is trying to improve quality care and safety and the communication. And I think that what they raised the issue is definitely right. This would help. This conversation goes beyond just legal obligation with ethical obligation. Is really about you know, the or risk management. Is really about the communication about risk versus the benefit, and what is alternative. And so I think overall it would help to improve the you know, satisfactions for patients' care, and also satisfaction with the providers. And so with a goal to improve patient safety. So I would like to see the commission, I would champion for the commission to take on that. Thanks.
So Claire, do you have any comments about it? Have you read the document?
No, I don't have any comments about it. Thank you.
Would this be something to establish a work group then to work on this?
Yeah,
Mike,
that's
Yeah,
step
I
two.
think
okay.
Step
it
one
should
is determine whether you
wordsmithing.
want a policy, and step two is to form a work group.
Okay.
So I would point out that this is titled Guidelines from the Maine Board, not a policy from the Maine Board. That having been said, I think a work group to look at this is worthwhile, and I volunteer to be on it.
Do we
I
have to have a
agree.
vote?
I also volunteer to be on that.
If I may, I would be willing to volunteer, and we can look at the evidence, and based on what we just discussed in another group, what is the evidence what has been done, what is current law was said, and you know, to look at what the risk and benefit also having this type of a guideline. So I would be glad if I'd be allowed to participate. Thanks.
So, sorry, I blanked out for a moment. I was thinking of something, but so we don't have to have a vote. We think it's important to look at, and we want a work group. Those are the two things.
Yes.
Yeah.
Yes.
So do we need to, other than making that statement that we want this, that we're going to organize this, anything else we need to say at the business meeting tomorrow about it?
No.
Okay.
I should probably volunteer for this as well. I used to do a lot of education on informed consent. Maybe I could contribute something.
Yeah, I think there are a lot of us here who do these discussions. I also do education of physician and nurse anesthetists over this issue. Okay, we'll move on. Delegation of signature authority for credentialing, discipline, and rulemaking. Is that one of ours? Don't Was that the last one?
Yes, the informed consent was the last one. The
Oh, okay,
delegation of
good.
signature authority is for old business tomorrow.
Oh, that's for old business. Okay, good. I was just, when I cut it off in the packet, I didn't write what number it was or what it was on the agenda, but it appeared in that stuff. Okay, so that sounds like our committee is adjourned. Is that right?
All right.
Yes.
Have a good afternoon, everyone.
Thank you, everyone.
See you all
See y'all
tomorrow.
tomorrow.
Bye.